In our last lecture here on Chapter 3, we want to see how this theory of proportionality can be applied to particular decision makers. So the three that we'll look at are the patient, the healthcare provider, and then returning again to the role of the surrogate that we talked about in our unit on informed consent. So for the patient's obligation, um, the basic terminology that has been used for many years in medical ethics is ordinary versus extraordinary measures. And the way to kind of understand this in terms of proportionality is that an ordinary medical procedure is that which, all things considered, is going to produce more good than harm. So, pretty basic procedures and medications that are going to maintain and improve health, maybe with some side effects, but with a pretty good guarantee of a healthy outcome. Extraordinary means or measures are those which, again, all things considered, may produce more harm than good, but in this place, the patient is accepting the risks that this might not result in the proper proportion. So, in other words, maybe um, taking an experimental realm of drugs, or maybe taking chances on a particular surgical procedure that has a lower percentage. Now, both of these are within a patient's right under informed consent. But in terms of our focus on beneficence, we are hoping that patients' obligations are going to allow for ordinary, um, that we, again, with recognizing autonomy and decisions, we want to try to help patients accept ordinary means or measures. While extraordinary, again, are up to the patient's decisions about other goods. Let's turn to the healthcare provider. And here, your book talked about the medical indications principle. And this again states that, granted informed consent, a physician should do what is medically indicated, such that from a medical point of view, more good than evil will result. In other words, the medical benefits are to outweigh the medical burdens of the patient. Um, I just want to take a moment because it briefly mentioned that medical indications can be specific for physicians. There's also nursing indications principle. And I saw that kind of connected with the Code of Ethics and provision number 4, where nurses are to take actions consistent with the obligation to promote health and provide care. And under that provision, we see that there's a lot of coordination of authority, accountability, responsibility. And at times, nurses are even charged to assess the competency and complexity of the medical task at hand and to balance that with the care needs of the patient. So it sounds simple enough, right, to promote good and to minimize harm. But when you're dealing with multiple healthcare providers, and the role of the nurse is to really try to assess and balance out and delegate that care, that can be tricky. I want to mention the baby doe rule. It was mentioned briefly in the chapter. And this might be a case that we looked at last unit in talking about medical paternalism, where informed consent can be overruled. But the baby doe rule is the commission, actually from any hospital that receives federal funding, um, that will condemn the withholding of medically indicated treatment for infants. And then it goes on to define what withholding means: the failure to respond to an infant's life-threatening conditions by providing treatment, whether that's in appropriate nutrition, hydration, and medication, and treating the physician's reasonable medical judgment will most likely be effective in ameliorating such conditions. And so I just wanted to kind of provide a little context to this. This was a legal ruling that obviously has ethical implications, but it came in response to a number of highly publicized cases where it seemed that parents of newborn infants who had birth defects were not properly being treated. And while many of these birth defects were correctable, parents were basically withholding ordinary means of treatment and allowing the child to die. There are exceptions to the baby doe rule. If the infant is chronically and irreversible comatose, or if the provision of such treatment would merely prolong the dying and not be effective in ameliorating or correcting all the infant's life-threatening conditions, where the provision of such treatment would be virtually futile in terms of the survival of the incident. These are all cases where they're recognizing that, sadly, um, certain children are born with maladies where they're just not going to live. And the areas that can be debated a bit more, and your book starts to do this a little bit, is under hydration and nutrition. Um, and for those of you who want to look at the ethics of end of life, these are the areas that are often debated. We might want to say that these are ordinary means, that we should provide food and water at all times, but there are times in which that might simply prolong a painful dying process. So I'll allow those who want to focus on that more to look into it. Surrogate's obligation. So the obligation of the surrogate is to, and giving or withholding consent depends on the wishes of a once competent patient, and hopefully those wishes are known or can be deduced. So again, we saw this before. If we have an advance directive or a living will, this makes things easier for the surrogate. But there are two principles that your book mentions that surrogates might use to try to determine a patient's desire. And the two are the best interest principle and the rational choice principle. The best interest is where a surrogate acts in the best interest of the patient, disregarding the interests of others. So again, recognizing that they are not the patient, but trying to think about what the patient, what would be in the patient's best interest, regardless of other individuals and factors. The rational choice principle is where a surrogate is going to make a choice about treatment that the patient would have wanted if they were able to make it. So the rational choice principle is certainly going to imply that the surrogate has a very good working knowledge of that patient and that patient's kind of hierarchy of goods, which can include relationships and the interests of others. These are complicated, and I think what your book mentions is that there are a number of issues for a surrogate to really come to an informed decision. I just want to highlight two out of the four that are mentioned, but the quality of life problem is where we want to try to avoid, both for healthcare professionals and for surrogates, to make quality of life decisions about the worth of a person. The focus should be on medical treatment and medical outcome. And yet we know that these can often be complicated ones. This one at the bottom that I just want to mention is a conflicts of interest. And this is where particularly a healthcare provider subordinates the interests of the patient due to possible financial interests. And this might be the provider of a third party. So an example of this might be a physician who is getting paid from a particular drug company to promote their drug. And therefore the physician might be advocating that particular brand of drug because there's a financial incentive. Now, I would like to find out the law more specifically, but I think it is incumbent upon a physician to let a patient know if they are receiving funding like that. But ethically, anyway, you can see where if there's any potential conflict of interest in making a decision about a particular treatment, that a physician needs to make that clear. So we're going to just finish this slide talking about the healthcare provider as the patient advocate. That advocacy does not authorize the healthcare provider to overrule the patient or lawful surrogates, but it does when everything else has been attempted. So we're getting back into those cases where there's justified medical paternalism. But we can see throughout these two units that informed consent and beneficence can be in conflict. And lastly, it's important to note that when there is that conflict, it is acceptable for healthcare providers to refuse to treat patients. There are certain conditions to that. Now, certainly in emergency situations, healthcare agencies and professionals do need to treat patients. If it's life or death, there's not much choice. But a patient can be turned away if the provider feels like they are not providing the necessary skills to treat the patient effectively, if their practice is oversubscribed. But it can also mean that they just disagree with the patient's choice of health and pattern of choices. Even if that relationship is to be broken, it is important ethically that a healthcare provider to allow for a continuity of care. So this can be referring a patient over to another qualified doctor or nurse. But it is important to note that when a particular healthcare provider is feeling like they're not able to reach the goals of beneficence due to the decisions of the patient, you can go through a process to end that relationship. So I hope this section was helpful, and I look forward to our discussion.